Well, good evening, everyone, and thanks for joining us for a new form of education. We're calling it peer-to-peer, and tonight we're talking about the light adjustable lens platform. Now, we'll get into what peer-to-peer is in just a little bit here, but we're excited that you would all be joining us. As all of you are coming in live and coming through from your registration links, I wanted to welcome you to our discussion tonight. And tonight's discussion will be talking about premium technology in cataract surgery in general, but it'll also be talking about the light adjustable lens specifically and the LAL plus and the changes and difference between the two. In addition, we want to thank our sponsors for the unrestricted educational grant that was given by RxSight to have tonight's discussion. They're just one of the sponsors at Peer-to-Peer, and we'll let our two panelists and hosts and the folks running Peer-to-Peer talk about that here in just a minute. Well, now that you're all here, I want to go through some housekeeping items. First of all, I'm Matt Jensen. I'm moderating tonight's discussion on the light adjustable lens. And for 20 years, I was the CEO of Vance Thompson Vision. And like Dr. Vukich and others in the industry, we were part of the FDA monitored clinical trials for years as this technology was coming to commercial use. It's been fun to see how it's implemented. And tonight we're going to be really talking at length about just exactly how that works. Patient selection, marketing, when and how to use it, how do we talk about it. And so I'm excited about that, but I'm also excited to be joined by my friend John Vukich and by my friend Dr. Nick Bruns out of Summit Eye Care in Wisconsin. Dr. Vukich is a surgeon there, and Dr. Bruns, the optometrist there who does the light adjustments. And as we transition to the next slide, where we're talking about the difference between the LAL and the LAL Plus in tonight's discussion, I thought first we'd start with an introduction from you two and a little bit about what peer-to-peer is. So maybe Dr. Vukich, I'll start with you and have you just talk a little bit about your background with the light adjustable lens, but also we'll transition after Nick talks then about peer-to-peer in general. Dr. Vukich?
Well, thank you, Matt. Well, this is, I'm excited to be a part of this project. So the thought process was that this is going to be mirrored by what we learn at big meetings, not in front of the podium and the audience, but in the hallway, when there's the unfiltered discussion from friends as you're sharing lunch or dinner, and just what are you doing in a way that is meaningful and not colored by any other influence, except for we all want the same thing, which is provide great care, give good insight and good tips and hints, and quite frankly, how do you do it? How do you make it work? And so that is the whole premise of how we wish to proceed. We've done this in a way as an unrestricted educational grant, so we are not encumbered by some of the restrictions that are issues with, FDA and with labeling issues. So all of this is something that we find both nourishing as an educational venue and really exciting as an opportunity. We're starting with the light adjustable lens because we've had such great experience with that. But we're going to be talking about other technologies. We're going to be talking about how do we make our practice both sustainable, profitable, and quite frankly, how do we provide the best possible care? And so to that extent, I think we're going to do our best to make this a meaningful opportunity for spending an hour with us on a regular basis.
Matt, I think you're on mute.
Sorry about that. And how about you, Dr. Bruns? Maybe a little bit about you.
Yeah, so Nick Bruns, I've been practicing for about 10 years now. I joined Dr. Vukich at Summit in Milwaukee in January of 2020, which, if you can recall as clearly as I can, that was a great time to start a practice cold. Holy cow, it was pretty tense there for a little bit. But we had the luxury of really designing the clinic. I think we were the 19th or 20th to do the light adjustable lens, what we're going to talk about tonight. And we had the luxury of designing our clinic around it because we were so excited about the technology. And so since then, I mean, John, you and I have gotten to know each other really, really well. It's I consider you a mentor and a dear friend. But we've been able to grow our practice in a way, we've learned a lot of stuff along the way. I shouldn't say it's all been smooth sailing. There's been bumps along the road. But we've had the ability to really see how to position this technology in conjunction with a lot of the other technologies that we're going to talk about in this series in a way to maximize outcomes, improve efficiency, and just build a practice from the ground up. And so that's something that I'm really excited about. So refractive surgery is a passion. All things anterior segment surgery is a passion of mine. And coming from an optometry point of view is pretty unique. I don't fit contact lenses. I don't do glasses. I work exclusively in surgery. So I do bring a little bit of a unique perspective from my optometric training, but working in ophthalmology for my entire career. So like John mentioned, peer-to-peer really is designed to be a collaborative effort. We want to be interactive. And so this works best if everybody out there participates. If you ask questions, you make comments. This is not meant to be the two of us lecturing on how to do a certain thing. Quite frankly, we're still learning too. This technology is still relatively new. So there's things that we haven't seen. Although we've seen a lot, we've done well over 1,000 implants, light adjustable lens implants since 2020. There's still things that are left to be uncovered. So this works best if there's a collaboration. And like John, like you mentioned, I mean, when I go to national meetings, there's certain things that I do get from the podium, but most of my education comes at the bar after. I get most of what I take home, all of the stuff that I take home from a meeting comes from my discussions that I have just candidly in the hallway or, at the coffee line to get a coffee in between lectures. It's all of that is valuable. So we're trying to recreate that in a virtual space.
Well, and that's a perfect segue for me to talk about what you all see on your screen right now, which is a click to submit question. One of the things we wanted to do is find a way for you all to get your questions answered as part of our discussion tonight. And so we've got a few topics we're going to work through, but we don't mind doing some off-roading. And so as you have questions, click on that submit question link that you can see right there on your screen. It'll come to us and I'll curate those and get them in front of the providers here. And we'll have them be a part of our discussion throughout the entirety of tonight's session. So we won't save those for the end. We'll do them in real time. So keep those questions coming and I'll send a few reminders, state a few reminders as we go. So that's a little bit about peer-to-peer. And just one more piece of background before we segue into some discussions about the light adjustable technology specifically. This was born out of an idea that you had, Dr. Bruns, really with a lot of your optometry cohorts, and also since being inspired by all the education that Dr. Vukich does. But you were doing something called RX Insights pretty regularly. Mm-hmm. And I do want to harken back to that because I do think that spirit of education is really part of why this is going to be so successful and why we're creating it to be in the forum that it is, where there's a lot of discourse, a lot of feedback, a lot of questions. So be sure to put your questions through the click to submit question button. Okay. Now let's get started. So the very first topic for us is really just the light adjustable lens platform itself. And I thought I'd open the discussion first with you, Dr. Vukich. You've been there through it all with the development of this technology. Talk us through exactly what the technology is, what it does, and why you wanted to find a special place for it in your practice.
So this is an overnight sensation that has been over 2 decades in the making. We heard about this quite a long time ago as the Calhoun lens and the various iterations. And obviously there's been refinement to the point now where it has become available both in the U.S., Europe, and around the world, quite frankly. So I've been watching this very carefully. The whole concept of being able to create a refractive outcome with a lens after it's been placed in the eye, that is something that is just intriguing. And the fact that they have now gotten to a point with the delivery system for the adjustment as well as the implant technology itself, the polymer that it's made from, and the way in which it can be so accurately recontoured, it's been a significant improvement in the ability to deliver consistently a great result. So I've been a part of this from the very beginning, but we've been working with this technology now for 3 years. And I think many on this platform have worked with other premium lenses, whether it be a multifocal or an EDOF lens or a trifocal. And we know that they have certain challenges. I mean, every single multifocal lens, if you look at the FDA data, has had a 5% dissatisfied or very dissatisfied outcome in their subjective responses. And that accumulates in your practice. So when I was doing more, of the lenses, the panoptics and the other lenses that, have tried the intermediate and the high ad and the mix and match and all the things that seem to be fashionable, quite frankly, people are talking about, there were different concerns, different unhappinesses that were expressed, but yet there were still unhappinesses. So we started using the light adjustable lens, and quite frankly, that just went away. It has made our practice that much easier and patient friendly. And quite frankly, I suppose I'll get in trouble, but this is the purpose of this format. We simply don't use multifocal lenses anymore. That has all but disappeared from our practice. We use toric lenses for the high corrections, but it's really been a shift in how we view providing the ultimate quality of care. And to that extent, I'll defer to Dr. Bruns, because this is a team effort. And quite frankly, it could not and would not have happened without that team approach. And so from my perspective, there's some tricks to making this work. Maybe not tricks, as there is common sense. How do you make the secret sauce? Well, it's no secret.
Yeah, I mean, you hit it on the head. It's a team. It is a team. And when I talk to patients before surgery, I explain that, Dr. Vukich, you can't have a good outcome if you don't start with a really good surgery. You have to have a good surgery. And that comes with a good surgeon and good skills and good technique. But the ability to customize vision is just so encouraging for patients. And I think at the real root of every patient that comes in, at the real root of their desires, is the ability to have control. They're at their most vulnerable state when they come in. I mean, they've never gone through eye surgery before. The idea of getting your eyeball cut open and put back together, that's terrifying when you really think about it. To us, that's normal. I mean, we do that every single day. But to a patient who's never gone through it, that's horrifying. So the ability to give them some element of control in a procedure that will last the rest of their life is just huge. And it's hard to put a price on that. I mean, obviously we do. This is a premium product, but that ability to do that is just, it really sits with patients. So yeah, like you mentioned, I mean, we haven't done a multifocal lens in probably 2 years. I don't know, John, last time you put a multifocal in?
Yeah,
2021 maybe?
We just simply don't do it. So I'll tell you one of the bellwether moments that I had. Warren Hill is a personal friend, and I've sat on committees with him. And I'd say if there's anyone who you could point to and look at as one of the gurus and individuals who have helped us understand IOL calculations and power calculations, it's Warren. I mean, there's really a handful of other people who could maybe be in the same sentence, but Warren is the leader. Warren, and I can talk about this now because he actually did a video that he showed at the ASCRS. Warren Hill had the light adjustable lens in both of his eyes. I mean, okay, you want to talk about a recommendation by someone who probably is unparalleled in his understanding of optical quality. If that's his choice, we're not going too far wrong.
What was his refractive error, John, right out of the gate?
Oh, I don't have that exact detail. I do know that he is 2015 uncorrected. He flies antique warbirds, and he flies them in formation where they are like within 36 inches of other planes. So he said, my vision's really important to me. And I'm going, yeah, I guess it really is.
Wow.
So he's quite happy with that. Yeah.
Dr. Vukich, I'd like to just clarify a couple of points from your overview. And that's the one of we hear about how there's great technology for monofocals now, and there is, right? Especially when we look at where we were decades ago, and then we also talk about the advancements that have taken place since 2005 when we started doing premium in diffractive IOLs, fixed IOLs that are have multifocality, and things like that. But you said that there's a 5% dissatisfaction rate. Is that on the multifocal, or is that on the complex, for the premium IOLs?
That is on the multifocals, whether it's a high ad, low ad, trifocal, every single one that has gone through the FDA. Subjective patient responses are now a very important part of what the FDA looks at for approval, and every single one of them has in that range. And again, we've had a lot of experience working with the FDA. I've presented to the panel several times, and so this is something I pay close attention to. But it also mirrors our response, where you get individuals who just simply, we talk about neuroadaptation. I just think it's they get tired of complaining. I mean, quite frankly, I don't know that they ever say, yeah, my vision really got good. It just actually, it's just my new reality. And there you have it.
That's a significant amount of chair time with folks. And I think it translates not only to the patient experience, right, but also the provider's experience. And I just wonder, does it give you, I mean, well, one of the things I want to talk about is optics and outcomes and things like that. But just from a peace of mind standpoint, where does it sit with you to as something that you recommend for your patients? Is it the lens that helps you sleep better at night? I mean,
Yeah. Yeah, 100%. Absolutely it is.
Yeah, there's that for sure. But at the end of the day, what we all want are patients who are satisfied and happy, and who, and you do get that with multifocal lenses. I don't want to dismiss it as a segment that is absolutely not the case. What I can say is that, well, let's put it into perspective. Go to the next meeting. We've got an AAO meeting coming up. There was the ASCRS meeting. Take a look at the courses and how many courses are on how to handle the unhappy multifocal patient. Yeah, okay. There's always a course like that. There's always lectures on that. Now take a look and see where you can find the whole course on how to handle the unhappy light adjustable lens patient. They don't exist. They don't exist. And we're going to see more as we go. I'm sure there will be, because you can't please everybody. But that is just mirrored by our experience.
Yeah.
Well, I want to talk for a second about the optics, because one of the things that people talk about is adjustability or not, that there's superior image quality, and in the regular sessions and CME and things like that, we don't get to talk about those kinds of things, and especially guys like me who don't understand optics anyway. But talk about how this compares to other things that you've experienced. You're happy with the visual outcome?
Yeah, I mean, so at the end of the day, it is a monofocal lens technically. I mean, you do get the level of pristine vision that any monofocal lens, a good quality monofocal lens, would provide. You don't get the dysphotopsias, the optic noise that we kind of word massage with our patients about multifocal lenses. That the halos and the glare that you notice, that just means the lens is working. You don't have to have that conversation with this lens. So being a monofocal lens, it gives us advantage to use this in patients who would normally not be at all a candidate for any other premium product. So people with macular degeneration, we've done plenty of patients with severe glaucoma and hemifield defects, patients with corneal pathologies. We can use this in those patients. Now, the beauty of it is that now we have the ability to extend the depth of focus by increasing spherical aberration in the non-dominant eye. So you're really broadening that depth of focus. You're providing that patient with really functional reading without having to transition to, quote, monovision. We don't use that term in our practice. We don't call it monovision. We call it blended vision. And the reason is because I've had so many patients who come in and they're like, well, I've done contacts before. I tried that monovision thing and it just was terrible. I almost drove off the side of the road because I was so imbalanced. Patients who have done monovision and didn't do well with it do very well with a light blend with this, because you don't have to sacrifice the non-dominant eye as much. Normally, especially with the traditional LAL, we're sacrificing it on average, maybe a diopter and a quarter or so, maybe. Not much more than that usually, and most people are less than that. And what that affords them is very comfortable reading. I tell them that you should be able to see your phone. You should be able to see a menu at dinner. Your speedometer should be no problem. You'll probably have to pull out reading glasses for small stuff. Or if you want to sit down and read a book for a couple hours, sure, reading glasses will always help. But they don't have that anisotropia problem. They don't have the imbalance because that minus 1.25 eye can still see 20/25 at distance. It might be a struggle, but they can get it. And now with the LAL Plus, since that was just introduced a few months ago, that's even better. We don't have to sacrifice the non-dominant eye even more. On average, we're ending up at about -3/4 or so. And with the option to further extend that depth of focus, we're able to just reach, more an improved reading status. And so patients are just much more comfortable. So that 20/25, 20/30 non-dominant eye is now 20/25 plus. And it just is a much more comfortable thing. So, but being a monofocal lens, you're not splitting light, you're just stretching it out. And the spherical aberration, when it's done properly and in the appropriate patient, really can work to your advantage.
And when you say that, because when I hear you say it's a monofocal lens, I start to think that it's locked in perfectly. It's one distance and that's what you get. And I get tripped up by understanding the difference between that and then extended depth of focus, right? Which is really what you're saying. And monovision is kind of when those two are just set at those precise distances. And then the extended depth of focus has some overlap then, or makes it a little easier because it's a range.
Exactly. Yeah, you do retain stereopsis and depth perception.
Okay.
So I'd say the LAL in its unaltered state provides probably the same depth of focus as maybe an Eyehance. I know, John, what do you think? An Eyehance or an Aspire lens, you're getting something out of it, but you can stretch that further.
Okay, so Nick, talk about the recipe. So how do you optimize the depth of field with the LAL when you are using what are the parameters? Where does the lens have to start? Where do you have to end up? And how does that influence the depth of field effect?
Yeah, so there's a couple conditions that you have to meet, and that's on the first treatment. So if you're moving, you want to be moving in the myopic direction to -0.5 or greater. Both meridians in your power cross have to flatten, or they have to steepen. They can't flatten. So you can't be moving from like -75 to -50. You have to be moving from -50 to -75. So as long as you're moving in the myopic direction in both meridians to -0.5 or greater, you will induce about an extra quarter to, I think, 3/4 technically, or 0.37 diopters of extended depth of focus technically. In reality, I think you're probably getting about a half diopter of added EDOF. You can only do that on the first treatment. You can't do that on the second one. So let's say, hypothetically, I have a patient coming in and right out of the gate, they are -0.5. If I go to the LDD and I type in -0.5 as my manifest refraction, -0.5 as my target, that will initiate added depth of focus because you're still targeting that -0.5. None of the meridians are flattening. They're both just staying neutral. You're still going to get that added depth of focus. But let's say, hypothetically, for instance, you end up at -1 right out of the gate. You can't move hyperopically. You won't add that negative spherical aberration. You need to move in the myopic direction. And so that's how you can, there's a bit of an art to this. But in patients where you're certain they want that reading, take advantage of it. And that can work in your favor big time.
So what I've found is that the patients who tried monovision in the past and with the contact lenses or some previous point, and they just hated it, and just said, I can't live my life like that. That's crazy. They actually do really well with the blended vision. I never call it monovision as I'm discussing it with the patients. It's a blend. And so what you don't have is alternating suppression. You don't lose binocularity. You don't lose binocular summation for quality of vision. So you commonly would end up 20/15 or at macular tear film potential in the distance eye, and you'll end up maybe 20/25 in the near eye. But really not a noticeable difference unless someone's really doing the refractive salute. But the near on that is, the equivalent of a +175 or even +2 add, and it's really functional. So you're not losing the quality of vision at distance, which is really what drives monovision dissatisfaction. It's not so much the near, it's the distance. And this has been a very good solution to that. It truly works.
Did you call it the refractive salute? Is that when they do this?
Yes, exactly right.
I've never heard that before.
I like that. That might get borrowed after this conversation.
Well, I talk to patients all the time about not doing that because we're treating the entire visual system. We're not treating just a couple eyeballs. It's their brain. It's their entire system. So really don't do the refractive salute, because if you look for it, it's like if you give me a baseball and tell me to throw it with my left hand, it's going to look terrible. My right hand is my right hand for a reason. But man, if you give me 100 pounds to carry upstairs, it is nice to have them both. And they work together. They each have their strengths and their weaknesses. So you're treating the entire system. But the refractive salute, okay, I'm going to use that.
Okay, so
Gentlemen, I want to ask a question. Go ahead, John. Sorry about that.
Well, I was going to say, you wouldn't mind if we went off-road a little bit, and so I'm going to do that for a moment. There was an excellent question that just showed up, and one that I think really we need to answer. So I don't offer multifocal IOLs. What do we do with patients whose pupils are less than 6 millimeters? And that is a very good question. There are FLACS patients out there. There are female patients on dietary supplements and whatnot whose pupils also don't dilate. That is an excellent question. Well, the answer is, how much do they dilate? And, again, this is very important to just say this is off-label, and we tell our patients that. But 6 really isn't a bright line that has to be achieved. So, Nick, if you want to give a little bit of our experience as to, where do we draw the line? Where do the wheels fall off? And to the folks from our site who are listening, cover your ears, and we're just going to tell you what we do, because that's why we're here.
There's really not much of a line. I mean, if they've got pinpoint pupils, I guess we're going to probably not go that route, and that would be probably risky to even get the lens in at that point. I mean, you're looking at a complicated case in the operating suite. So patients, we don't need them to dilate 6 millimeters. I mean, that's more than we have to. Ideally, we can see both haptics, and ideally you can see an edge on the lens when you're doing the treatment. But in reality, we don't get that all the time, not even close. What I always do if I have a patient who doesn't dilate sufficiently, at least not to see both haptics, we'll do a third treatment. And to do that, you have to really create a dummy account on the LDD, and then you'll do a third lock-in. So you create a dummy account on your LDD, and your clinical trainers can help you with this on how to do this. But then you just bring your patient back, treat them as a second final lock on the dummy account on your LDD, and that'll just polymerize all the remaining macromers. So if I don't get them dilated enough, I just tell them straight up that, hey, we're going to have to bring you back, because there is a risk that if we don't do a third lock-in, that lens could be warped by the sunlight. And it could happen. I haven't seen it, but I don't really want to find out, because if that does happen, there's only one thing to do, and that's take the lens out. So just do a third lock-in. But other than that, it's been fine. I mean, our patients with really small pupils have done very well. Now, part of that is probably aided by small pupils. There is a meiotic, pinhole effect, which we will take it. If there's an advantage to be had, we'll take it. Patient's thrilled. They're happy. So however we got to that 2020 or 2015 vision, it doesn't matter. That patient doesn't care. We got it. And that's what matters.
So
that's really good.
There is a point. There is a point at which too small is too small. Okay. And where is that number? And that's what I would say. Okay, all right, you guys are talking trash here. You haven't really said what you do. There is a number. And it's probably between 4.5. 4.5 is kind of where the wheels fall off. And again, the labeled indication is 6. But I can tell you we have done many, many patients who are less than 6, and they do absolutely swimmingly.
I would say 4.5 is probably good, because dilation fatigue is also very real. And so if they don't get to 4.5 at their initial evaluation, by the time you get to their final lock, they're not getting to 4. They're probably getting 3.5. And so that probably is a good benchmark. And I would say we haven't done anybody that small. By the time that we finish them and they've been so fatigued from all the drops, there's definitely some iffy pupil dilations, but again, they end up okay. And everybody has done very well.
Gentlemen, I want to keep us moving here. I want to get one question asked, and then we're going to transition to this next slide when we put it up there, which is about the difference between the LAL and the LAL plus. But before we do, I want to talk about a specific question about a practice that offers both Toric and Panoptics and Vivity. They wanted to know, how have you transitioned your conversation from the extended depth of focus IOLs and multifocal IOLs to patients who have friends that haven't had the LAL, but they had the other lenses instead? How do you talk to those patients about their options?
John, what do you think? Want to take it?
I'll start by saying, okay, I have experience with all of those lenses, and they're good lenses. And I have no doubt that you have friends who are very happy. And quite frankly, we have used these lenses in the past, and but we've moved on. We are now using what I would put into my eyes. It is what my wife is going to have in her eyes. It is what we use now for the individuals who have very acute needs. We've done this with multiple surgeons, on multiple pilots, on multiple professional golfers, individuals who really need that tack sharp quality of vision. And that's just the direction we have gone. So I don't say that one technology is bad. I just simply say that in our experience, this has been better. And it is, at the end of the day, it is what I will have in my eyes when the time comes.
Yeah, I've got, family members and friends who had the best technology at the time, who are still happy with their decision for some of these technologies. And there's still a lot of great innovation taking place out there too. So I think even based on the, pupil size, there's a conversation that needs to be had about every offering and its merits. The thing that I do find particularly compelling, though, as a consumer, is there's something in healthcare where the patient is in charge. And there's just very few offerings like that. I do think that patients understand that when they get it, they're really attracted to that. They're in the driver's seat. They can kind of direct their own path and walk around with it. It's impressive. Let's transition for a second about the salient differences between the light adjustable lens and now the LAL Plus, which has launched within the last year or so. Dr. Vukich, I'll start with you on this one as well. And then, of course, Dr. Bruns, you're doing a lot of the optics work post-operatively. We'll transition to you.
So I'll be brief because Nick has so much experience with this. We were one of the clinical investigation sites for this, validating the technology and the outcomes, and the results have been spectacular with the LAL Plus. We do have to be cognizant of abnormal corneas, post-LASIK corneas, post-RK corneas, in which we use the standard light adjustable lens. But you lose like a letter or two at the most because of the change in the optics on the LAL Plus. So, but if you're talking about going from 2015 to 2015 minus, nobody notices. It's a non-issue. And so the LAL Plus is really our go-to lens for anyone who has a standard cornea. And I'll defer to Nick because you've done so many of these and you see these patients on a regular basis.
Yeah, I mean, the big difference, the LAL Plus does have that central asphericity that's going to provide a little bit more depth of focus. And it really does provide a little bit. I mean, but when you're searching for perfection, a little bit goes a long way. And it does give you just a little bit of an enhanced depth of focus. So most of our patients on average were between minus 0.75 and minus a diopter in the non-dominant eye. And that gets them J2 pretty comfortably. It really does. And the way the defocus curve is set, it also equates to 20/25 plus distance vision in that minus 75 eye. So it works in both directions. I mean, the difference is that it just has a little bit extra. But if you look at the data, it does, I think you lose a line, or not a line, a letter at distance with the LAL Plus. And like John mentioned, 2015 versus 2015 minus 1. It's a non-factor in most patients. Now, for our virgin corneas, healthy eyes, LAL Plus all day. That's what we do because these patients have every benefit without giving anything up. Patients that have aberrated corneas, post-LASIK patients, you really got to be careful. And we've used the LAL Plus in post-LASIK patients before, and it has gone okay. But you are introducing a lens with very slightly more aberration to a system that's already aberrated. So you just have to be very careful. And in those patients, I really hesitate to induce the added negative spherical aberration. So like I talked about previously with the ability to add that negative spherical aberration on the first treatment, use that ability and that power with extreme caution in your aberrated corneas, your post-LASIK corneas, your post-RK corneas. Definitely don't do it because you're just aberrating a system further that's already really aberrated. You're just introducing so much more optical noise. So be careful with that. I don't think the LAL is going anywhere. I think the LAL Plus is fantastic, and we will use it for all of our very healthy patients. But the LAL, the traditional LAL, still has a place. And right now we're pretty much 50-50. I mean, we do a lot of patients who have aberrated corneas. We really push limits on how to use this technology. So more than half our patients are not perfect, pristine corneas or perfect, pristine maculas. And so for those patients, we'll take all of the advantage of the LAL and just give up a little bit of that reading ability, but we want to preserve the functional distance as much as we possibly can. So the LAL traditional will be our go-to for those.
You know, we have this entire generation for which the LASIK stopped working. Okay, I'll put that in quotes, but 25 years ago they had LASIK, and now they've got nuclear sclerosis, or they've had some change in their refractive error, and the LASIK wore off in their opinion. But of course, we know what's happening with the lens, and they're actually the ones who understand the value, the personal value of not needing glasses, and they want to go back to not needing them, and they're way more motivated just as a group. So yeah, we see a lot of post-refractive patients now, and they're drawn to this technology. They do their homework and they find out what we can offer. And so, yeah, as Nick said, about half of our patients are in that category. And quite frankly, we're very happy to have the standard light adjustable lens, which is just the go-to for those.
Well, and it's such a nice category to have something for people who you already made happy in the past to come back at another stage of their life for this and as part of cataract surgery, but also for a potential refractive lens exchange even before cataract surgery is done. And Nick, I'm really glad that you said what you said, because some practices ask, okay, so so how much longer are you going to use the first LAL, the traditional LAL? Is that being phased out by your practice? And it sounds like you've got a real use case for both, which is exciting to hear.
Yeah, it's not one size fits all. It's not. And just like the lens and the adjustments are themselves, they're not one size fits all. You can't just categorize every patient. You have to look at it case by case. So look at the cornea. I mean, at the very least, look at the pentacam. Obviously, you're going to the topography. If you have an aberrometer, use it. Look and see where the aberrations are, what kind of aberrations they are. And, there's no steadfast rule for how many aberrations are too many. We're kind of getting a feel for it. And so basically, if they're post-refractive, we pretty much stick to the LAL for now. And we're pretty 50-50, but both, it's great to have them both. So I would encourage our site not to phase out the LAL, because I think there's a spot for it.
Well, let's use that to transition to our next question, because our audience is anticipating where you gentlemen are going with the conversation. The next topic is to talk about surgical targeting. And there's a few questions on our lists related to surgical targeting. What are we shooting for? Are we shooting for plano, et cetera? I'll lift those up here in just a minute, but I want to remind everybody, if you've got questions or comments, click to submit question bar on your screen. That'll allow us to get it to a format that the doctors and we can all see together and decide how to answer. Plus, we'll also be able to keep track of the questions for use afterwards and make our education even sharper. Okay, so first of all, I'm going to ask this question on surgical targeting. Thinking about how you said it's not a monovision setup, just curious about what your typical target is for the near eye. That came in from one of our audience members.
Yeah, so surgically, we target right around plano with both.
Okay.
And the question I always get to is, which A constant do we use? RxSight introduced the 119.1 not long ago. The older version, previous version, was 118.4. The A constant of 118.4 typically left you a little bit more hyperopic. And that was by design, because they want, ideally, the way the technology works, it works best if you're moving in the myopic direction for several reasons. The treatments are more predictable if you move in the myopic direction, just like myopic LASIK. But then it also leaves you the advantage of having that added depth of focus on the first treatment. So for us, we use 118.4 because that's what we're used to. So typically we're shooting for our first minus lens, and that leaves us right around plano. We just kind of know how to work that in our system. We didn't want to change any process and end up with patients who were more hyperopic or, refractive surprises. You want to leave yourself as much wiggle room as possible. So long story short, ideally plano with both eyes. And the other thing that I usually tell people too, I mean, eye dominance changes. It really does. You may come in thinking that a patient is right eye dominant. And, in Wisconsin, we live in the world of hunters and, big gun people. So I always ask them, where do you sight your rifle? They may say the right eye, but, once we get the cataract out, they switch. Actually, my left, it does switch. And so you don't want to commit to one eye being your non-dominant eye because, again, leave all options on the table as you go through this process. And so for that reason, plain on both eyes.
Oh, that's a great response, and a learning for me that can change over time. Another beautiful part of this offering. Another question that's coming through on the surgical targeting category is related to Hex-K. Can the UV light penetrate Hex-K?
Thankfully, we never got quite that aggressive in the Wisconsin market. I had done some hyperopic ALK, which I, again, at a younger, more foolish part of my career, but never did any Hex-K, so I have no experience with that. I would imagine you could get through a Hex-K. I still don't see any reason why. We do get through the RK eyes, and we do have some 32 cut small OZRKs that we have seen and done. And so I would imagine the amount of aberration from the scarring and the corneal incisions is probably similar enough in terms of what it could influence. And that has worked. The issue, of course, is stability after the cataract surgery. How long before the cornea reaches a stable end? And so the agreement, or at least the recommendation, is 2 weeks post-op. And in those patients who have, incisional keratotomies, and we can wait. We've waited as long as 6 weeks to get a stable refraction. And the patients, we just tell them, look, we need to have a non-moving target, and that is the key to this. We also, maybe just another cautionary tale, we kind of got too clever by half, thinking, oh, we're going to do our treatments at 7 days, just because why 2 weeks? And it turns out we didn't have nearly as good of results. So one of the things that has been a recommendation to go a full 2 weeks, we absolutely adhere to that. And actually, I've had this conversation again in the hallway with many of my friends who do a lot of these, that they all found the same thing. It's like, don't try to be too clever. Don't start doing your first adjustment at 7 days or 6 days. You're not going to get the same results. Wait the 2 weeks. Wait till everything's stable.
Yeah, especially for RK patients, our patients with incisional refractive surgery, we do wait about a month standard. And I tell them before we do surgery that when we schedule these appointments, we try to pre-appoint as much as we possibly can so they kind of have an idea of when they're coming to the office for the treatments. Just because we schedule an LDD, a light adjustment, doesn't mean that we're going to do it. I always reserve the opportunity to not do anything, because once you get down that path, the main variable you have is time. And this is not for the impatient patient. I tell them that right away. You got to work with me. Trust that I've got your best interest in mind. And this is a lifetime thing. It's not a 2-month thing. So work with me. So if your refraction is not stable, the analogy I always use is like putting on a golf course, right? We're putting. And so in order to putt, you have to wait for that ball to come to a rest. Unless you're like Phil Mickelson a couple of years ago. I don't know if any golf fans are here. But you have to wait for that ball to come to a rest before you putt it again. And once you putt it again, you can realign, reputt, and you have a way better shot at getting it in the hole. But if that ball's still moving, you don't know where you're going to hit it. And so for those RK patients, that golf ball could be moving all over the place. And they usually are pretty aware of that. They're usually comfortable with the idea of their vision changing throughout the day. I've had patients who have 3 to 4 pairs of glasses for different times of day because their corneas are just so unstable. So you got to give them time.
So, Nick, one of the things you've done that is just absolutely brilliant is you line up all of the post-op adjustments and appointments, and right on through the lock-ins. And so they know that they're going to have these visits. And where the brilliance is it seems like a failure if you have to add one that they weren't waiting for. And it seems like you're a hero if you say, nope,
Yeah.
actually, you really don't need the last one or the last two, and we're going to finish up early. And it shows that you did a great job and you did it sooner, as opposed to like, no, you need a third treatment, which is, not uncommon, but if they're expecting it, it's not a failure. It's just what they knew was coming. So I think that's just a bit of the psychology.
Make it easy on yourself.
Yeah. I do think that transitions nicely to this idea of managing patient expectations and not doing it after the fact, right? Dr. Bruns, you were talking about how you're telling them up front how that choreography might go, what to expect. And even with the post refractive patients who might have unstable corneas, to give them that kind of verbal anesthesia of, this might take a little bit longer. You're kind of encouraging them. I'd like you to just give some examples of patient types and how you talk them through the process, or how you talk to them about what they should be using their vision doing, so when they come in, they're prepared for their adjustment. How do you choreograph the aftercare in such a way where they're ready to participate in their adjustment?
Yeah, I think it goes back to the team, right? So they go through Dr. Vukich for the initial evaluation, as patients should. They should meet their surgeon and have a proper evaluation. But I have at least one touch point with every one of these patients before surgery. Now, whether that be a phone call, sometimes we bring them back because, let's say, they've got a really particularly dry cornea and we want to get repeat measurements. If they come back for repeat diagnostics, I'll be there and I'll talk to them. And it's all about discussing expectations from a different point of view. And so Dr. Vukich and I sometimes have this good cop, bad cop thing, which works very, very well, where there are a lot of positives about this lens. There definitely are. But some patients only want to hear the positive, and they think that, well, because I'm paying all this money, I'm going to be able to see through walls. And if I can't, I'm going to be really unhappy. That's just unrealistic. And there are limitations. And so happiness equals the difference between reality minus expectation. So if you set those expectations, or expectations minus reality, set those expectations to an appropriate level. And if you nail it out of the park, then you are a hero. And so sometimes we do have those different point of views, and we just provide different analogies. Like I've already exampled tonight that I speak in sports analogies. And if somebody's a sports person, I can usually relate to them pretty well. But maybe Dr. Vukich has a different way of putting it. And you've done this for a couple extra years, past what I've got. So putting it in a different way helps. And we're likely able to overlap enough to capture how that patient learns. Everybody learns very differently and they absorb information differently. So we're trying to capture that from different points of view. So it's all about the team. So I like to be there in the beginning, and then I'm going to finish up at the end. So it's just a full circle moment.
One of the things that helps me talk about when we're talking about patient expectations is this notion of that the light adjustments might be better to delay them, right? If they come in and they're not quite ready, and that's what I hear doctors talk about, which leads to this question about the usage of the glasses. So let's talk about that for a second, because that's an outward signal that someone is going through this process, and tacking on a couple more weeks might, to the regular and casual viewer, seem like a bummer. For people to be in these glasses for an extended period of time. Talk about that and how you manage expectations with the usage of the UV light glasses.
Yeah, the glasses aren't as big of a deal as I thought they would be. I mean, patients kind of like them. And I joke with them that these are the most expensive pair of glasses that you're ever going to buy. I mean, they just come with an adjustable lens, but they are the most expensive pair of glasses you're going to buy. It's not as big of a deal as I thought it was going to be. We do ask that they wear them outdoors. The label says you have to wear them all the time still, but we do ask that you wear them outdoors during daylight hours. In the car, we do ask that you wear them still, because you're getting sunlight and we just can't guarantee that your windshield is filtering out the specific wavelength. And indoors, though, and especially at night, we don't need you to wear them. It's totally okay.
Yeah, well, we tell the patients that, it's really only outdoors during the daytime that you need to wear the glasses. And we've been doing that now for over a year, actually way over a year.
Several years, yeah. Yep.
Yeah, and there just simply hasn't been any issue. And so I thought initially that there would be a lot of pushback for wearing the glasses, that the patients would just reject that summarily as I'm not going to do that. Turns out it's not been a big negative at all. And ironically, it's actually been a conversation starter with their friends who said, well, wow, okay, what did you do? Why are you wearing those? And it's another conversation starter when they stop wearing them. And people will ask, how did it go? And so, from a practical standpoint, it's ironically a practice builder. We never thought of it that way, but practically speaking, that is exactly what happens.
Yeah, it's a cue, and that's what I've observed as well. Not to mention the people from the regions that I work in who save the glasses when they're done and just keep wearing the sunglass version because they're like, well, I like them, you know.
Yeah.
So it's an investment, so they keep them. Okay, well, gentlemen, I'm just going to the board here to see what other questions
Matt,
we
can I
can
make a
help.
comment? I want to go
Yeah,
back on
please
something
do.
that we talked about a while ago.
Mhm.
We kind of passed through it, but talking about toric lenses, I don't want to say that we don't use toric lenses anymore. We do. The advantage of this is that we can. Toric lenses do have. I mean, John, what's the percentage? How many of them can actually rotate? It's a percentage that
Yeah,
can rotate.
I don't know the exact number, but it can happen.
Yeah.
But there's a limit to, and there is a real limit to how much you can get with the light adjustable lens. So in
Hmm.
higher corrections, we definitely use a toric lens, or we use a femtosecond laser. Quite frankly, it was something that I, was kind of a little slow. I was a skeptic, to be honest with you, and I was part of the original investigational team many years ago, and I just never saw it as solving any sort of problem that I had in reality. So we were kind of late to say, all right, this makes sense. Well, I've really come around. I've totally changed our opinion on that. We use, I guess we can just talk about technique. We can tell what we do. I use the Lens AR laser, and it's like 30% of our patients
Hmm.
will have a small amount of astigmatism, and then we'll give them a better correction because of that. We'll use it with the LAL patients because it gives you a really nice, round, consistent capsulotomy, which again, is just part of the whole high tech way in which we do this. So we're using the laser, and the patients really like that, and we use it to mitigate astigmatism so that we cut it down to size, we no pun intended, so that the LAL can get the rest. So we incorporate other technologies to make that possible, and FLAX has been one of them. And so I'd say yes, it's about 30% of our patients actually now end up getting FLAX.
Yeah, and that's been a big practice builder for us too, just financially as well. I mean, it's not as expensive, for patients who do want a premium outcome, but they don't want to maybe jump to the LAL. But in the LAL, I mean, keep in mind that there are a finite number of macromers in that lens. So patients, I think our cutoff is about 1.25 diopters of corneal astigmatism. We will do, with the Ally system, AKs to debulk the corneal cylinder as much as possible. That leaves your macromer reserve, so you have more ability to go up or down if you need to. And so using that to our advantage, it just gives us way more wiggle room. And so, for instance, patients who have a lot of corneal astigmatism, let's say they have like 2.5 diopters, that's outside of the range of the LAL. Technically, you might be able to get it, but it is definitely technically outside of the range. If you can debulk that, you're going to give yourself just so much more workability, and that just leaves the customization on the table.
I
So
think that's a really nice way to talk about the technology. And isn't it great to think of all the technologies we've used over time and they find clever ways to interact with one another and really maximize the benefits? I think that's pretty fun to see how that's evolved over since 2011 when all the femtos came out. I want to just ask an operational question. This will be our last one, just be for the sake of time. But there's one of our attendees started the LAL in their practice. They're still trying to find how to schedule the LDD patients perfectly. Sounds like they might be early in their program. It's taken a couple of hours from start to finish to get these done. Is that ever going to be less? And how do you process them? Where do you refract them? Do you do it at distance, at near and intermediate? What's your process like? And I'll start with you, Dr. Bruns.
Yeah, so we batch schedule these. So for instance, my Mondays all day I'm doing LDDs, and I've got other appointments kind of sprinkled in there as well. But we usually do 8 o'clock 8:30 and 9 o'clock, we'll have LAL patients come in. And so I do personally all the refractions, and I consider it like a counseling visit at the beginning where I'll refract them. I do trial frames in office where we just want to see if they can tolerate a little bit of the aniso. I let them walk around, and I talk to them about their options. I'll dilate them. We use 1% tropicamide, 10% phenyl, and then we'll dose them with 1% tropicamide every 15 minutes or so. I don't usually let them wait for more than an hour to dilate, because at that 1 hour mark, you're really getting some diminishing returns. The pupil is going to start to come down. You don't really want to use 10% phenyl more than once because there are cardiac risks, especially in our elderly patients. So we really try to use that only once. And then we do the treatment. And so I think the key to making this functional and efficient is having a good staff too. I've got techs who understand these patients. They're very, the big thing that we look for when we hire staff is just customer service. You have to be able to relate to somebody and just manage people who are waiting a little bit, but we really don't keep them in the office more than an hour and a half. It's fun because I think the funniest thing is actually we keep all these patients on the same day. So they're sitting in a room together and they've all got their glasses in hand, and you've got something so uniquely in common with another individual. I've had people go out to coffee after their light treatments who never knew each other because they've got something in common. And it's just this weird kind of matchmaker side of this thing that I never thought would happen. But it's not a bad thing. And we keep it fun. I mean, we have the TV on. We let them watch what they want, listen to music. We have a little speaker in the LDD room to keep it light. I let them pick whatever kind of music they want, whether it be, Christian rock or, hardcore rap. I don't care. Whatever they want to keep them comfortable. And we rock out. It's fun. And the staff loves it.
So it's a really good point about keeping them all together, because commonly there'll be a mixture of someone who's getting their last lock-in in the same room waiting with this person who's getting their first treatment, and that person's been waiting for 2 weeks, and their vision was pretty good but not great, not exactly everything they thought, and then here's the person getting their last lock-in just going almost evangelical about how amazing their vision is and how you're not going to believe it tomorrow and just wait. And it melts the anxiety away. It really is this self-fulfilling kind of joy that gets spread around. But what I really want to comment on is that this is the elephant in the room with the light adjustable lens, and that is the chair time and the commitment of time. And the reality is there's work involved, and you expect to have additional visits. You have to make time for that. And in our practice, it is a team sport. There's no question that Dr. Bruns has become, Nick has just become one of the experts in this. He does it incredibly well, and together it's made both of us better in terms of our ability to deliver quality care. So to the extent that that's possible in every practice, I think there's going to be variances, obviously, but that is the ideal situation. If not, have the refraction done. You can have your tech at the room, have everything programmed in. You can come in, put the contact lens on, and do the adjustment. So there are surgeons who do all of them themselves, and that's possible. You can do it within 45 seconds to 2 minutes if you have somebody waiting there and having everything ready. So there's ways to make this happen, but the real bottom line is that it's so worthwhile. Don't let that get in the way of providing this incredible premium care for your patients. You get paid well to do it, as you should, and the patients are paying a fair price to get the best possible vision every waking moment of every day of the rest of their lives. What's the value of that?
Mm-hmm. Mm-hmm. Those are really good words, doctors, and I appreciate you sharing them with us. The one thing I just want to close with is that it's an energy giver, not only for you, Dr. Bruns, and you, Dr. Vukich, and the patient, but it also really energizes the team. When they're supporting these patients and they get to see them a few times. And so you're right, it is the elephant in the room, but I do believe, not so unlike the glasses themselves, it's much ado about nothing. It's just because it's going to become more standard to have this kind of choreography. I want to thank you for participating in tonight's peer-to-peer program, gentlemen. It was a great session. We covered a lot of ground. And I want to thank our sponsor for the educational grant to talk this way about the technology. I also want to remind you that we have sessions like this coming throughout the fall. Our upcoming sessions here on the next slide are September 10th. We'll have one on October 8th. And we'll list all of them and their topics as soon as we know them at the peer-to-peer.academy website, peer-to-peer.academy. And that's where you can go to follow us and learn more. Make sure you talk to your colleagues and friends and partners about this forum. We think it's a very honest and true way to talk about usage of the great technologies that exist in our industry. Gentlemen, thanks again for joining us here tonight. Thanks all the audience members who participated. We are now adjourned.